Good morning, everybody, and welcome to the Series A webinar series. We are opening this program, and the association will do on a monthly basis a series of updates in surgery. We have today famous, important surgeons, and I will ask them to contribute with some updates in robotic surgery. We'll start with the first one, Professor Alessio Pigazzi, a professor of clinical surgery, University of California, Irvine. And the topic is updates in colorectal surgery. Please, Alessio, welcome.
Thank you, Piero, and good morning or good afternoon to all the participants, especially the CRSA members. It's a pleasure to join you at this time. I hope you can see my screen. And I will give a brief update on robotic colorectal surgery in 2020. These are my disclosures. And I will share first with you some slides that are provided by Intuitive Surgical, and they come from the Premier database. And I think they give a pretty good idea of what the status of robotic surgery in the United States especially is over the last few years. If you look at 2008, the minimally invasive adoption across several procedures. In general surgery, the use of robotic surgery was really minimal just over 10 years ago. The only really significant use of robotic surgery was for rectal cancer, and it was in single digit compared to laparoscopic or open surgery. If we look just 9 years later, the proportion of rectal cancer and hernia surgery done robotically is quite impressive. And also for colon resection, the numbers are growing very substantially and noticeably. I have a strong interest in rectal cancer surgery with the robotic approach, and we did our own analysis from the National Cancer Database, looking over the time span of 2010 to 2016. And the curves, I think, speak very clearly that the use of robotic surgery is growing very steadily, while open surgery is dropping very fast, and the adoption of laparoscopic surgery is slowly trending down. So I predict that by now, or in the very near future, the proportion of rectal cancer operation done robotically will surpass both laparoscopic and open approaches. If we look at the publications in robotic colorectal surgery, this is straight from PubMed. As you can see, there's been a fairly exponential growth in the number of publications over the last many years. There's over 1,000 publications over the last decade, and the peak is at about 140 publications a year. And just in 2006, it was less than 5. So very impressive growth and interest. I think especially for rectal cancer, which is really the mainstay of the robotic approach in our field, the market has really spoken. Rectal resection is still the most common application in robotic surgery. Open TME is declining, and transanal TME, I think, has received a lot of interest in the last few years, but it does not seem to be making a big dent in our procedural adoptions for reasons that are, I think, complex and beyond the scope of this talk. What are the main reasons for the success of robotic rectal cancer resection? Are they marketing forces, the learning curve, peer pressure, or actual technical advantages? And I really think that all of the above have had a major role in explaining the success of robotic rectal resection. I think we have better data now than we ever had before with robotic TME, but there's still a lot of very biased data, a lot of case reports and single institution series, and even administrative data sets, which carry their own bias and I think do not represent the highest level of evidence. As you know, I was fortunate to participate in the ROLAR trial, which to this day is the only large randomized rectal cancer trial comparing robotic to laparoscopic surgery, and trying to assess if the robot was superior to the laparoscopic approach, mostly in terms of technical feasibility, and that translated into a lower conversion rate. We estimated a 50% reduction in the robotic approach. The surgeons were very experienced in both laparoscopic and robotic operations. There were over 470 patients participating. And these are the results. As you know, the reduction was only 33% in conversion in favor of robotic. So it did not achieve statistical significance, but I think that this is a clinically meaningful point. And I think that the current evidence strongly supports that. If we look especially at the more difficult cases, such as male patients and obese patients, the reduction in conversion in favor of robotic is even more dramatic, and this did achieve statistical significance, although in a subgroup analysis, statistical significance has to be taken with a grain of salt. But I really think that this is highly clinically relevant, and I cannot stress enough how so many rectal cancer surgeons have embraced the use of robotic specifically for this reason. In terms of secondary endpoints, there's really nothing new. I think that experienced surgeons who understand the oncologic and anatomic principles of an operation can achieve good outcomes and good postoperative morbidity and mortality results, regardless of the approach. Now, cost is a very important issue, and Roller did a very thorough analysis of cost in both approaches, robotic and laparoscopic. The average cost in robotic surgery was about £1,000 higher per case. This translated into an incremental cost effectiveness ratio of 70,000 quality adjusted life years. And it was considered not cost effective in the UK because the NIS is willing to pay up to about £30,000 per quality. And this may be different in different countries, but in the UK that funded it, this was the result. Clearly, this is clearly very closely tied to the cost per case, and it follows logically that if the cost per case was a little bit less, the robot could conceivably be very cost effective. Genital urinary function does not seem to be different, again, following the same principle of understanding anatomical barriers to an operation. The robot does not seem to provide better genital urinary function postoperatively. What about colon? I think the most interesting thing that has happened in the last few years, as a lot of you probably know, is renewed, because there is nothing new in our field really, in intracorporeal anastomosis, especially for right hemicolectomy. Again, these are procedures that have been done laparoscopically in some centers of excellence across the world for many, many years, but the technical hurdles were always somewhat prohibitive for the majority of operators. The advantages of an intracorporeal anastomosis are the ability to choose the optimal extraction site that, as we know, results in a significantly lower hernia rate, especially if you avoid the midline and use fan and steel incisions, less manipulation of the bowel, decreased risk for twisting and obstruction. However, there is a need for advanced stapling and suturing skills. And there is a lot of talk in our community centered around the notion that the robot might make these approaches easier. And frankly, the evidence is a little bit mixed. I think, as we saw at the beginning of the talk, the adoption is increasing, but the evidence is kind of all over the place. I'll show a few studies. This is a systematic review and meta-analysis of robotic and laparoscopic right colectomy conducted between 2000 and 2017. 11 comparative articles with over 8,000 patients, and they found that the robotic approach resulted in a longer operative time, but lower conversion rates, same morbidity and mortality, and higher hospital cost. If we look more thoroughly and into the different types of approaches, this is a very interesting study from Italy, just published last year, comparing, again, another meta-analysis, comparing not just laparoscopic to robotic, but comparing open, lap-assisted, meaning with an extracorporeal anastomosis, totally laparoscopic approaches, and robotic approaches with over 5,000 patients. What they discovered in the analysis was that actually the anastomotic leak rate was highest in the open approach, followed by the laparoscopic assisted approach, followed by the robotic approach, and the lowest anastomotic leak rate was found with a totally laparoscopic right hemicolectomy approach. The reoperation was highest in the open approach and lowest in the totally laparoscopic approach, and hospital stay, excluding the open approaches, was higher in a laparoscopic assisted compared to a robotic or totally laparoscopic approach, suggesting that in experienced hands, you can achieve a very good results with a totally laparoscopic approach and probably decrease cost. But again, the evidence suggests that the majority of surgeons prefer to do intracorporeal approaches with the robot, and this is for reasons that are obvious and inherent to the technical advantages of robotic surgery, specifically, I think, with complex intracorporeal suturing, which is really made advantageous by the robotic arms. I think that in our field, and probably in every field, what we can say is that the robot does provide an incremental performance advantage over the equivalent laparoscopic approach across the spectrum of technical skills. Both master surgeon and average surgeon or neophyte, I think, will experience an increase over time in their performance level compared to what they can achieve at the top of their laparoscopic skills. What I don't think happens is that an average surgeon of this level of technical skills with the use of the robot can become a master surgeon. And this, I think, is a fallacy that I've seen many times in my career, and can possibly result in people stepping on in situations that are dangerous and possibly resulting in bad complications. And I know Piero will talk a little bit about that today. There are other areas where robotic colorectal surgery, I think, is making a mark over the last few years. One that is very interesting, we published a paper, is robotic ventral rectopexy for a variety of pelvic floor dysfunction, including obviously rectal prolapse. There is no doubt that this procedure is rendered a lot easier and more accessible, not just to colorectal surgeons, but also to urogynecologists, because of the easier in suturing and access to the deep pelvis. This is a procedure that on average requires 6 to 10 sutures, and I think it's made clearly easier by the robotic approach, and these patients can experience a very fast recovery. Complex diverticulitis, it's something that I've begun to embrace in the last few years, especially when you have big phlegmonous masses involving the bladder or the pelvic sidewall. I think the robotic arms allow you to dissect with much greater comfort, take down fistulas and so on, complex adhesions in a much more controlled environment with much greater, with significantly greater comfort at the especially ergonomic level for the surgeon. And a growing interest, again, some publications in the last year or two in multi-organ, minimal invasive multi-organ resections and pelvic exenteration, something that has been done also in other fields. So in conclusion, it's clear that robotic colorectal surgery is growing steadily in the United States. The evidence, in my opinion, is that the robot is still most beneficial for rectal dissection. There may be advantages in colon resection that I think await testing in large comparative studies. Cost considerations are still a barrier to adoption, although I think that with increased competition and increased availability of robotic system, the cost of robotic surgery may decrease, and this I think will invariably result in wider adoption. Thank you, and it's a pleasure to be with you today. So I cannot hear Piero.
Sorry. I say thank you for the nice presentation, very concise, very precise as usual. Unfortunately, we don't have much time available. A very quick question for you. There is any emerging innovative technology that could be incorporated into the robotic platform that basically is an artificial intelligence prepared platform that might increase the functional outcomes that, in my opinion, will be the next way of evaluating quality of minimal invasive surgery in terms of identification of nerves or selective lymphadenectomy. Do you think that there is some innovative technology emerging in this field?
Yeah, well, what I've been waiting for the most, because most of what I do is cancer, and I've seen some, prototypes and early designs, I think is augmented reality, to provide true, I think, image-guided surgery. I think that especially when you deal with oncology, as you know better than me, Piero, I think the ability to navigate with precision is sometimes an incredible advantage, and we are not quite there yet. But I think that there's a lot of companies, and I don't want to go into the detail because some of the things that I've seen are proprietary. I think there are a lot of companies that are working very hard to be able to provide that, and that is something that only a robotic platform, only computer-assisted surgery will be able to provide. Nerves, I'm not aware of a lot of strides made for the identification of nerves. As you know, there's been a lot of hype around ICG. I think ICG in colorectal surgery is still something that needs to be studied better. The current platforms that we have not resulted in a dramatic improvement, I think, in our ability to assess perfusion and diminish the risk of anastomotic leak. I think we are waiting for a better and more objective tool that allows us to quantify blood flow and bowel perfusion. These are the main things. As you know, there will be others in the near future with the new platform that are coming, and I think it will be a lot of fun to be participating in this technology.
Thank you so much. And then hopefully we have some time at the end to have a general discussion. And now let's move forward. I would like to invite Professor Eren Berber, a clinical professor of surgery, University Cleveland, Ohio, and welcome. I think he will give us some updates on advanced application of robotics in endocrine surgery. Please, Eren.
Thank you very much, Piero. I think it is difficult times. This webinar is really great to have an idea about what's going on and catch up with academics. I have some consulting agreement with companies, but nothing related to this presentation. So to give you an update on robotic endocrine surgery, this slide will give you an idea about the applications. The pie chart shows that about in 10 years, we've done close to 500 cases, predominantly adrenals. For adrenals, as I assure you, it's almost become standard. Thyroidectomy, there are some issues, and I'll talk about it. Parathyroidectomy, again, in very selected cases, and also for neuroendocrine liver metastasis and pancreatic tumors, the robot also has an application in our program. So what is new with robotic adrenalectomy? If you look at the different approaches, I would say that over the last years, the most significant evolution has been understanding how to perform robotic adrenalectomy in obese patients. And this has been dramatic, that learning to use the fourth arm and indocyanine green has really converted difficult adrenalectomies in very obese patients into more straightforward procedures. As you can see in this video, this patient had Cushing, BMI of 44. Counter traction is very important. In addition to the fourth arm in these patients, we also use this liver snake retractor, and we mount it to the bed rail. And having this, and then the fourth arm, then the case becomes a very straightforward procedure afterwards. I think this has been the most dramatic evolution for us over the past years. And for the sake of time, I'm not going to show much of the video, but as you can see, there's significant perirenal fat, and then using the indocyanine green frequently gives us a little bit more information about the correct plane to follow in these cases. I think these have been the two major advances in our technique over the last years about adrenalectomy.
This is a robotic.
And let me silence this as well. And then the other advancement, I think, has been maturation of the technique for the posterior adrenalectomy, especially with the use of the XI, which gives us much more ability with the docking in tight body compartments. And this is a patient with a pheochromocytoma involving the right adrenal gland. And as you can see, the ICG has been standard, really shows you the vasculature and the plane between the tumor and the retroperitoneum well. And in this case, which was a pheochromocytoma, you will also see that the ICG shows demarcation between the pheochromocytoma and normal adrenal tissue. Since this was a unilateral disease, we were not really doing a cortical sparing adrenalectomy, but in a patient with bilateral disease, we use this feature to help figure out where to divide the adrenal gland. Our approach has been 50-50 between lateral and posterior approaches. And I'm not going to go into too much detail, but just very briefly, we are selecting the patient for posterior approach in a very strict criteria. And we mostly operate on smaller tumors and a thinner patient with the posterior approach. And the more challenging patients are done through the lateral approach. And the benefits compared to laparoscopic, for the posterior approach, we demonstrated that the operation is about half an hour shorter compared to the laparoscopic procedure. And the lateral approach provides benefits in terms of large adrenal tumors with less conversion to open and lesser operative time. With our experience with the obese patient, we're most likely in obese patients, the robotic approach is going to also going to turn out to be advantageous regarding outcomes as well. And most dramatically, we like this slide, which shows that with the robotic approach, the surgical field is more stable and less instrument changes, which improve the efficiency of the operation compared to a laparoscopic procedure. For robotic thyroidectomy, as you know, dramatic changes have happened. This slide shows you the options: the BABA approach, transaxillary approach, and the most recent, the transoral approach. I do mostly transaxillary procedure, and the improvements over the last year has been mostly incorporation of ICG routinely into this procedure, which enables you to see the parathyroid glands, as you can see here. And also with the contrast distinction, we got another bonus. You can actually see the nerve distinctly from the surrounding structures, as the nerve doesn't take the ICG. So that's been the kind of this change in our technique. But overall, as we all know, robotic thyroidectomy numbers have been stagnant. And this is actually work I did with Piero, and looking at our volumes after Intuitive's decision on not supporting robotic thyroidectomy. The numbers have come down, and the volume is much lower compared to conventional thyroidectomy. Most recently, as you all know, transoral approach has been described, and Dr. Hoon-Yuk Kim in Korea has been pioneering the robotic approach. These are some of the slides. At the Ohio, we have also introduced this procedure to our patients. Nevertheless, the main issue is the demand for robotic thyroidectomy in the US is low. So in Ohio, the demand for this procedure has also been low. But we know that from some other centers in the United States, laparoscopically and robotically, more bigger series are being reported. But overall, I think all of the procedures for robotic thyroidectomy are going to be bound by this consensus statement from American Thyroid Association, saying that remote access thyroidectomy has a role in a small group of patients who fit strict selection criteria. These approaches require an additional level of expertise and therefore should be done by surgeons experienced in conventional surgery and have a high volume, and also have a big experience with robotic surgery. So unfortunately, I think for robotic thyroidectomy, the numbers have remained stagnant. Likewise, it's possible to perform robotic parathyroidectomy either from a transaxillary or transoral approach. But again, the patients who are candidates for this operation are small. The patients have to have appropriate body habitus, identifiable gland on preferably ultrasound, and the operation, the amount of dissection is much more compared to a smaller conventional incision. But in appropriate patients, mostly patients with wound healing problems, this procedure can be done robotically as well through remote access surgery, as we show in this video as well. But again, the demand for this procedure, similar to robotic thyroidectomy, has remained low. I think in the abdominal abdomen is where the robot utility is highest. And we also have incorporated the robot into our neuroendocrine pancreatic tumors, as well as liver metastasis. And this case is a robotic spleen sparing distal pancreatectomy for neuroendocrine tumor, and doing the fine dissection. The robot has been phenomenal in enabling us to do the fine dissection, where we take the pancreas off the critical vessels, as you can see here, and suturing likewise is much more frequent in this operation, and then therefore really fits really well with the robot as well. And most recently, the single port, the SP robot, is another addition to our armamentarium. The Cleveland Clinic actually one of the first centers to perform operation using the SP robot, and I have done a cadaver lab where I tried to perform all the procedures as I showed you, and I see some challenges with application of this robot to robotic procedures, but I think definitely as the robotic systems improve, single port robots also I think will have a role in robotic endocrine procedures. But at this point, using this system in the cadaver lab, I didn't see that it could fit into our practice at this time. It needs some more maturation for robotic endocrine procedures, but obviously it has a higher use in some other specialties, and especially robotic prostatectomy, as you can see on this image. I think over the last year, the significant advances in robotic endocrine surgery have been mostly incorporation of indocyanine green, understanding how to approach a more challenging patients, and the transoral technique, which unfortunately hasn't taken off much in Ohio, but could take off in other the country as well as the rest of the world. Thank you.
Thank you, Eren.
Hi, I can hear you now.
Thank you, Eren.
Sure.
I think a nice, unfortunately, again, we have a very short time available. I'm particularly intrigued in understanding more about the reason why the minimal invasive robotic assisted thyroidectomy is not picking up in the United States, while we have in Asia so many procedures developed in this field. We are speaking about thousands of cases that are done with perfect outcomes, functional and oncological outcomes, including extended lymphadenectomy. In my opinion, there is a problem in the access. I don't think there is a low recast of the market. A patient, they would be interested. But either ENT and endocrine surgeon they have some technical difficulties in this approach. And my opinion is a question of training, mainly how to develop the tunnel to reach the neck. I've seen ENT completely lost in the creation of this tunnel, and then having difficulty in having a retractor able to expose well the structure. Don't you think that this could be a reason for this failure?
Yeah, I definitely agree. I think that's one of the biggest missed opportunities, because if you look at the rest of the world, so many cases are being done robotically for thyroid, but here, I think the main issue is like for us surgeons who are pioneering robotic surgery, we mostly work in tertiary centers, and most of the patients we get are not candidates for this procedure. I think that with more training and maybe more increasing awareness of the procedure and educating the patient, because even the patients that I see who are candidates, when you talk to them about robotic thyroidectomy, they don't want it. They're a little bit scared. And I think there's some negative press about robotic procedures like this. They think it's experimental. and they think it's just like a neck incision is the safest way to do it, which I wouldn't disagree. But I think for a certain percent of the patients, they could have the similar outcomes and avoid the neck scar.
And which are, in your opinion, the best advantage of using robotics, let's say, in adrenalectomy?
Yeah, I think that like if you're doing a posterior adrenalectomy, using the articulated system definitely makes it more efficient. So I think definitely for all posterior adrenalectomies, and for lateral, especially obese patients, I see a significant benefit. And now operating on a patient with BMIs, high 40s, 50s, and 60s is not a problem anymore because of the 4 arms and the stable surgical field. That has been really very helpful for our practice.
Okay, let's move forward in the best interest of saving time. Now we have Francesco Bianco, that's Associate Professor of Surgery, University of Illinois at Chicago. And what's new in hernia surgery? That's, I think, is a hot topic, at least here in the United States.
Thank you, Piero, for organizing this meeting, first of all, and it's very important that we keep working on updates even during these difficult times. I'm sharing my video. So when you invited me to give this presentation about updates, you know, I was thinking what are the most recent things that we have been doing. And to me, the most update thing I've been doing is the application of single port, the single port platform that Eren was mentioning before to inguinal hernia surgery. To be completely honest, this is so much updated that it's not even FDA approved yet. So I have to disclose that this is an off-label use of this technology. And we know that the device has been introduced last year in 2019, and it replaces the 2011 version of the single incision. Most of us are familiar with the old single incision. We know how the access through one single port was achieved using curved trocars and flexible instruments. And we all know about all the limitations of this technology. I remember when we went with you, Piero, to Intuitive, it was, I think, 2009, we saw the first prototype of the single incision, and the engineers were calling this project Vespa. So I put this analogy just to give an idea on how advanced is this new platform, because at the same time, the project for the single port platform was Ducati. So they were comparing 2 Italian motorbikes that clearly are completely different. The new platform is actually a revolution. It reestablished this triangulation inside the abdominal cavity on the distal portion of the instruments, and allows for this reason excellent internal and external range of motion, to the point that, as you can see in the bottom video, we can move 360 degrees around the port and changing multiple angles. The instruments are much more sophisticated. They are multi-joint, and they have again the end of wrist. And the camera as well is an articulated camera with the usual high quality 3D images. I've been using this technology since June 2019. I've done so far 90 cases, 34 inguinal hernias, and 55 cholecystectomies. At the beginning of the experience, I start selecting patients. Of course, I stayed away from the large inguinal scrotal hernias. I avoid the patient with short torso, and I will explain why. I didn't include patients with previous surgeries. The results were so exciting, and the system proved to be so efficient that they quickly start to expand the indication. And I start to expand indication to the larger inguinal scrotal hernias. I still evaluate them case by case. I include patients with short torso, and I included patients also with previous surgery. This is just an example. Of course, here cosmesis was not a concern, but just to say that we can push things because the system is particularly efficient. One of the big difficulties in applying this technology to hernia surgery is the working space of the system. The system has a range that goes in between 10 centimeters from the port to 25 centimeters from the distal aspect. And this is due to the fact that there is an hinge on the instruments that doesn't allow the instrument to retract more than a certain amount. So we try to overcome this problem. So for the first two cases, I did the supraumbilical access, which worked great. I was able to easily complete the procedure, great vision, great range of motion. But then we were losing a little bit one of the possible advantages of the single port, which would be the improved cosmesis. So I turned to a gel port into the umbilicus. The gel port allows to burp the single port device out a little bit more, gaining a little bit of space. This is a great device. I think is more indicated for a more advanced application. It can support the air seal, it can support an assistant port. But for this type of application, also in terms of costs, was not still the ideal solution. And the final solution came actually at CRSA last year, talking with other colleagues. I started using this Alexis retractor that is tied around the port to guarantee a sealing, and it allows really to move the port completely outside the abdominal cavity. As you can see in these pictures, the remote center is completely outside the abdominal cavity. And this gives us now all the space we need to do our procedure and to do our final suturing of the peritoneal flap, which is usually the critical part. Another trick, I just make the incision just a little bit smaller than the size of the port, and then I safely force the port in an horizontal direction, tangential to the abdominal wall, so that we can reduce even further the size of incision, which, by the way, after we suture it closed, is already smaller. This is a short clip of the docking part. The patient is in the usual setting, so in reverse Trendelenburg, tilted to the opposite side where the hernia is. And this is now the procedure. As you can see, now we are moving the entire arm. You can see that the transition is pretty smooth. The instruments are triangulating inside the abdominal cavity, and we can very precisely perform our dissection, I would say pretty much in the same way as we would do with the traditional multi-port technology. Of course, those are a little bit slimmer instruments, less strength overall, but for sure much better than the single site instrument where the instruments were flexible, so they were not rigid enough, and they would not have enough strength to grasp the tissue or the hernia sac. Here we are dissecting the pubic bone. Now we extend the dissection on the lateral aspect. And for sake of time, I will try to move forward a little bit more. This is the dissection now at the hernia sac once both sides are prepared. And again, you will see how efficiently we can grasp and pull on this tissue. This is a combination of dissection done with monopolar energy and then blunt dissection with by picking and separating tissue from the hernia sac. Again, extremely effective with perfect triangulation and vision. The camera is coming from the inferior aspect, and then it can be flexed to reach the ideal angles. Here we combine again dissection with monopolar energy. We do a wide dissection of the posterior aspect in order to accommodate the mesh and avoiding curling of the mesh. Here is how we introduce the mesh. We do it through the camera port. It's extremely easy, much easier than the 8mm ports for the XI. As you can see, it goes in very smoothly. And here we still have another port, the one on top, that is free all the time because I only use 2 instruments. So we can use that other port for an assistant to bring in sutures during the procedure. We are deploying the mesh. You can see how easily we can complete also this task. And here you can see the distance in between the abdominal wall and the port because the port is floating. we can do our suturing much more easily, of course, now compared to the single site. This is the last step. Again, also this one is very efficient, and the times are overlapping with the multi-port timings. Here we are doing now the running suture of Vicryl 3O to close the peritoneal flap after the mesh has been placed. And again, you can see this is a very smooth step again, thanks to the distance that we create using the floating docking. This is a bilateral inguinal hernia. I will skip it for sake of time. This is another interesting video. This is a combined procedure. We did it with the urology team. The patient underwent a partial nephrectomy, and he also had this large inguinoscrotal hernia with intestine inside. So at the end of the procedure, I took over to repair the hernia. It's interesting because for their procedure, they use an assistant port. So we use that port to do some recording, as you can see now, of the robotic device at work while doing the hernia repair. The anatomy here is a little bit tricky because the patient is in lateral decubitus, so we have to adjust a little bit our point of view. But again, you can see how we have good triangulation, good working space. And again, the end-of-wristed instruments really make a difference. It's almost like doing the traditional multi-port surgery at this point. It's not much different. We close the flap at the end. This is the final view, and you can see again the setup of the single port. You can see the articulations, the distance from the port, and the mobility of the instruments to perform the tasks required for the surgery. Those are the results. Those are 28 patients with, as I said, 34 total hernias. We had 6 bilateral hernias. The BMI ranged from 20 to 41, so we were able to use this technology also on heavier patients. We had 3 associated umbilical hernia, 1 patient with a previous prostatectomy, which is usually our nightmare for this type of surgery, and the patient I showed you before with the previous laparotomy. Docking time, extremely short, average 3 minutes. This means that the whole setting is quite easy. The mean console time overlaps with the multi-port. We have 36 overall with 31 minutes for the unilateral and 49 minutes for the bilateral hernias. We had 2 draping issues that require us to redrape one of the arm, and this takes time, and 1 expired camera because these cameras have a limited number of uses, which require to get a new camera for the sterile supply. All patients went home the same day with an average time of recovery of 118 minutes. We haven't seen any incisional hernias so far after an average of 182 days of follow-up. So in conclusion, we can really say that this is a safe and feasible procedure with excellent cosmetic results, because now we are really doing almost scarless surgery. The technology is much more sophisticated that allows to expand the indications for single incision surgery. We have seen in our experience that the efficiency of the system is almost at the same level of the multi-port approach. We have been able to do multi-quadrant, multi-specialty surgery, so this is another big advantage. We are still working right now on costs. We know that the instruments themselves are slightly more expensive, but usually a good cost analysis comes after a complete standardization. So once the learning curve is completed, and that's what we are doing, working also with the urology team. And we have a project also evaluating different closure techniques to reduce the incidence of incisional hernias. We have almost 420 single site cases too, and so the experience keeps building up. And I will stop here and thank you again for your attention.
Thank you, Francesco.
Thank you.
Very well done. I think it's very interesting. I think this is a very good update. In your opinion, which are the most urgent technical implementation of the system to expand the indication, because of course I see a perspective, a huge perspective in reopening the nodes problem. So a flexible probe or better instruments, lack of some devices like suction, for example, and which is the most urgent implementation that you
Yeah. No, thank you, Piero. This is a very good point, because right now we have a limited set of instruments. I think that suction, we were able to overcome this limitation introducing our own cannulas with like tracheal suction device, and that works great. So like I've done it in cholecystectomies and things like that. What we really need at this point to make the big jump is a more advanced type of energy. Right now we rely on monopolar and bipolar energy, but as soon as we can bring in more advanced energy, I think we can really expand the indication. The urologists are really doing more advanced things with the limited amount of instruments, but I think that advanced energy will be the next big improvement for this technology.
Okay, let's hope we can do some discussion. We are a little late. I don't know if we can prolong a little bit. It's an interesting webinar. And it should be my time. And I would like to share with you, because it's such a huge topic to speak about updates in HPB, that I wanted to focus on apparently a very specific issue. I will run fast because everybody knows that biliary injuries are still, they have a big impact in our practice. And even the open cholecystectomy, there is a range of injuries that is up to probably 0.9, but laparoscopic cholecystectomy is higher. There is a growing evidence that robotics may have an impact in decreasing these injuries. I skip some of the experiences that are appearing in the literature, including our own experience at University of Illinois. I think this is a reason, one of the reasons why I think that the future perspective of robotics in simple cholecystectomy, in my opinion, is huge. It's a very simple learning model for surgeons. It allows a daily practice. It gives you superior microsurgical, stable platform capabilities, and that might contribute in decreasing. For sure, some virtual technology implemented image, as Alessio Pigazzi mentioned earlier on, they might increase recognition of the anatomical structure. That is one of the main reasons why surgeons there making injury of the bile duct. And it's a good bridge for more complex HPB. I think some of the specialties still struggling. If you're looking at cardiosurgeons or other specialties with the application of robotics, because they don't have a daily model to practice. And I think in HPB, the gallbladder is an easy model. And I think it's a cultural investment for the future health system. I think prices, they will invariably go down. I skip some of these slides in sake of saving time. There is not complexity of, to speak about biliary injury, there are so many different techniques and kind of reconstruction, depending on the level of the injury, the type of injury. But one of the most frequent technique is the hepaticojejunosis that is utilized for the most severe application. And we published a couple of years ago our initial experience. Now we have more cases because we are a referral center of the first 14 patients that were treated robotically. I know that the usual strategy was to do open surgery for these complex biliary injuries, or even to drain and wait until there was a dilation of the bile duct. I think this, of course, this kind of strategy would entail an increase of cost and morbidity for the patient, a lot of litigations and legal issues as well. And so the idea, initial idea, why not to try to minimize everything? Why not to try to make the repair immediate? That was ideal. It happens, the injury, immediately you can repair, even though you have a very small duct, and you can do microsuturing in this situation. And so we approached the situation in this case. So of course, some of the patients are referred from outside the hospital, and the range of time that was passing from the injury to the repair is not always ideal. But let's just see some few examples, and I will. This is a terrible injury. There is a total ablation of the extrahepatic bile duct, and this is immediately the patient was transferred. Was drained in outside hospital. There was an endoscopic stent that was going from the duodenum inside the left part of the bile duct. You see the stent is in the surgical field. So the patient was not septic, and we decided to go ahead immediately. And you see this with some careful exploration and some blunt dissection, we are able to make a full examination of the surgical field. This is the distal stump of the bile duct that is sutured. And once we had a perfect anatomical recognition, there were two separate ducts, the right and the left, and we prepared the Roux-en-Y in the usual fashion. And now the posterior row, you see, is done with a Kasai type technique, anchoring the bowel loop to the hilar plate. And you may understand that here the key point, the technical point, is to be able to do well the corners of the suture where you have the ducts. So interrupted stitches, and you are seeing perfectly the inner part of the duct, and with interrupted stitches, you are able to enter into, see, this is the left duct, and you see the mucosa perfectly. And then this is the key point to have a good outcome, to be able to do perfectly the two corners of the Kasai technique, where you have the opening of the duct. And then, of course, then you tie all the single sutures, and you have a perfect, you might add some anchoring suture to the anteriorly, but you have a perfectly done suture, and usually put some fibrin glue at the end. There are other examples, some are terrible, but I think I don't have time. ICG might help in recognize that this is an example of a delayed reconstruction in a patient that had 1 year before a cholecystectomy with the injury of the right, and that was totally disconnected. The patient was treated with a transhepatic drainage of the right system, and for some reason she was left alone with this transhepatic biliary drainage for 1 year, and in the meantime she got pregnant. So this is the video of the reconstruction when the patient was pregnant, and she was losing a lot of bile with the transhepatic drainage. We decided to go back during the pregnancy and to make the hepaticojejunostomy And so this is the right hepatic duct that was recognized and reconstructed. I have multiple videos of some of the terrible situation and some intrahepatic reconstruction as well, but we don't have time to see all the videos. What about the outcomes? Surprisingly, they are doing fantastic in terms of complication rate, conversion, only one conversion, and 30-day readmission rate, only one patient for a chronic myeloma that was drained. But even most importantly, you know that the outcomes of this reconstruction is long-term. The long-term, and we have some patients with a 5 years follow-up, and it seems that it compares very favorably with open surgery. So I think, in my opinion, this is one of the most innovative application of robotics in advanced HPB surgery, repair of biliary injuries. And which is the future. I think better development of intraoperative images. I think we already have a very well performing microsurgical platform that is the multiport XI. And with a good training, a good experience in HPB, I think you can deal with the most complex application. In particular with the biliary injury, I think we can change the modality of treatment of this condition, decreasing the complication for the patients, speeding up the recovery, and also very interestingly is the decrease of the litigation level of patient. Only one patient out of the serious patient went back and suited the original surgeon because they thought that the repair done minimally invasive didn't change much their quality of life. So this is another important aspect that you have to keep in mind. So I will close here and I don't know if you have time for a general discussion. I have to shorten up my presentation because we were a little in delay. We can open up some general few minutes of discussion about the perspective of our specialty. And I'm anticipating that I will organize other webinars on a specific specialty or a specific organ procedure, like Eren mentioned thyroidectomy, understanding why we are struggling with some technical difficulties in development, or single site expansion with indication, as nicely Francesco anticipated, or improving the functional outcomes in oncological surgery, as Alessio told us. So if you have any comments, and also I would like to understand if there are questions coming from the attendance of the panel. In the meantime, please, if you have a few comments, please go ahead.
Here, I have a question. Maybe the audience would be interested as well. Can you talk a little bit about the newer systems that are coming? I know that the Medtronics made some release of how their system looks like, and maybe we could all give a little bit of information about what other systems might be coming, or which one is really getting to the market.
I can do general comments. Some of the systems are not in the market, and I had the chances of seeing and testing some of them, but I'm connected with NDA that I signed, so I cannot disclose some of this information. In general, let me say that I'm sure that the market will see a number of new devices and prototypes, because there is no question that digital-based surgery will be the future. I think we can discuss days and days, months, and to compare, let's say, fake trials. Please don't misunderstand me, but I'm convinced that there are so many biases in some of this trial, like the roller trial. There are so many biases. Very experienced laparoscopic surgeons that compared with early beginners in robotics and so that is difficult to. But I think we have to have a vision. I think analogical surgery has limitations that are limitations connected with our capabilities, and digital surgery has unlimited number of implementations. So when the relation between the anatomical target and the human becomes implemented with artificial intelligence, that is the future. So it's clear that we will be there, and we will have plenty of companies that will be on the market. I'm sure that the prices they will go down. The speed of development will be faster. Let me ask a question. Are you happy of the instrumentation for liver surgery? I'm not. I think we need better tools. And why we have been waiting for years? Because the market so far for liver surgery has been very limited. And so the Intuitive did a marvelous job, but it was a little interested in putting resources and energies in offering tools to a limited group of surgeons. And this is why probably having more competition will help also Intuitive and other companies in investing more in different specialties that as I told, I'm convinced that even simple gallbladders around the world, they will be done digitally. I don't know if someone want to add some comments on this. Alessio, what's your opinion?
I agree with what you said about the instrumentation. Even in colorectal surgery, you know, the instruments have been somewhat lacking in a lot of respect. You know, I think that bowel graspers, for example, can improve. There is no doubt about it, to have a more intelligent, and I think Intuitive in their, you know, in full disclosure, has made some improvements over the years, but there is no doubt that this has lagged behind some of the other technologies that they have invested so heavily in. A lot of the I think missed enterotomies and injuries that happen in robotic surgery at the beginning of the learning experience have to do just with that. I think with the inability to detect, you know, the amount of pressure that is applied to the tissue and so on, and this could be, I think, improved significantly given the technology that is available now. I wanted to ask you, Piero, what's your thought on ICG in cholecystectomy, especially for acute cholecystitis? It is a field that I've not really followed very closely, but do you think that it's possible to expect a reduction in biliary injury with the consistent use of ICG for cholecystectomy, especially in the setting of acute cholecystitis where the cystic duct might be occluded and so on?
The answer, Alessio, is absolutely yes. Of course, this technique has to be refined. Now we have a lot of uptake by the liver that is covering the biliary structure. And also the penetration of the light is limited when you have inflammation or thick tissue thickening like edema, like you might have in cholecystitis. It's difficult to have an optimal visualization. But the future developments, for example, artificial intelligence with subtraction images. You can use the speed of time of uptake of the colorant and to make a subtraction of the early images. And so you can clean up the images of the bile duct. And I can tell you that as an academic institution, we are done hundreds of gallbladders, and since we started using regularly the ICG visualization, residents they feel more comfortable in completing the procedure. And we had at this point probably a couple of thousands of cases without any major inconvenience or injury. Of course, it's a limited number. We should see probably thousands of cases, and we should do trials for that. But I'm absolutely sure that with a better refined technique, this is the future. No need of X-ray, and you can comfortably switch the vision a bit back and forth when you need. And we will have soon possibility of making elaboration of the images with implementation.
I agree completely with Dr. Giulianotti. In acute cholecystitis, still is very helpful to identify the common bile duct, even if the cystic duct is obliterated. So it still gives you some important landmarks. There is a question for the audience, and I have a question for Eren also, because always regarding the ICG, I saw these beautiful images of the visualization of the parathyroids and the nerve as well, using ICG. What is the timing of injection for that type of visualization?
Thank you, Francesco. I also really like the way you introduce single port to hernia surgery. We inject 5 milligrams of ICG when we are ready to look at the parathyroid glands, and it circulates. In 5 minutes, you get uptake in the thyroid and the parathyroid, and then over time, in the next half an hour or so, the thyroid uptake gets less intense, and so the parathyroid stand out.
That's beautiful. Those were very beautiful images. There is a question for Dr. Giulianotti, I think, from the audience. Dr. Verma is asking, well, of course, for everyone, but when do you think the robotic-assisted technology can be used for liver transplant, if this is something that you see happening in the future?
Thank you for this question, Dr. Verma. I don't know if I'm pronouncing your name in the correct way. I apologize if I do that. I think it's a very promising. And we did years ago the first worldwide living donor hepatectomy, living donor hepatectomy for transplant successfully. And since that time, there are centers mainly outside the United States where the living donation program it's a little small in volume. But in Taiwan, for example, there is a center that is doing regularly robotic assisted right hepatectomy as a part of the donation for the transplant. And also in Saudi Arabia, a German surgeon that is working there developed a nice successful program, and I think now has more than 100 cases of successful. And I think this is a nice application because you know what, one of the most difficult part is to do a precise preparation of the pedicles with microsurgical capabilities without endangering the safety for the donor. And so I think this is a very promising technique, and I do believe that the future is here. For other transplants like pancreatic and renal transplant, also here at the University of Illinois, we have a such a successful program that originally we started doing robot-assisted kidney transplantations in obese patients because the open technique in this category of patient is very challenging and connected with a high incidence of infection rate in the wound, and that is impacting even on the graft survival. But it's so successful, the program, with such a low morbidity and a fast recovery that now we are opening the indication to normal sized patients and also to cadaveric donation, not only the living donor program. So this is a very, as Alessio mentioned, when you have a complexity of dissection, as you may have in diverticulitis of the colon, or you have a very complex situation of reduced surgery, adhesions. I want to do a webinar on robotic treatment of adhesions, because it's a very interesting new chapter of this. When there are sophisticated need of technical abilities for microdissection, this is the best platform that you might have, the robot-assisted end-of-wristed instrumentation combined with the stability of the platform, the 3D visualization. So these are the best indication. And I do agree with Alessio that made a very important comment at the beginning. It's not that a robot is making you a good surgeon if you are not. If you are a learning surgeon, you can become a master. You have to be patient to develop your specialty experience at the best, and then on top of this, you can apply the robotic technique to achieve the Everest. That is my opinion. I don't know if there are no other comments. I think we're a little late. We can thank you, everybody, for attending, and I invite all of you to attend the next webinar, Series A webinar that will happen in July, and they will be focusing on role of artificial intelligence in the next generation of robotic surgery. Thank you, everybody.
Thank you,
Thank you very much.
Thank you, Piero. Thank you, everybody.
Thank you, everybody.